Should maintenance therapy after autograft be limited? I had the no position, and the reason being is that right now the current standard for maintenance therapy after autograft for myeloma is lenalidomide until disease progression. There have been some attempts to retrospectively look back and see whether or not a shortened course would be beneficial. It's still not clear, and if anything, it would suggest that maintenance until progressive disease, especially if the patient tolerates it, is the gold standard, in the sense that patients who received shorter periods of maintenance therapy and came off due to an adverse event, not due to progression, which wouldn't be fair if you were comparing. But those who came off for an AE had an earlier progression than those who were able to stay on maintenance. So really, tolerability is very important. There have been some studies from the German groups which have been presented in abstract form. One is looking at dosing, and this is after 6 months of lenalidomide consolidation at 25 milligrams. There was a randomization to 25 a day versus 5 a day, 3 weeks on, 1 week off. And there was a superior progression-free survival in the patients who got the higher dose. Those who got 5 milligrams, it didn't appear to be as effective. It's interesting in other trials such as myeloma 11, CLGB 100-104, IFM 0502, the dosing was higher. It was either at 10 a day or 10 milligrams, 3 weeks on, 1 week off. So there's sort of this Goldilocks phenomena. Should you get it at too high a dose, it may not be tolerated due to AEs. And if you're too low, it may not be as effective. So again, that's looking back in meta-analyses and retrospective looks. So the other trial was, there's another German trial that looked at 2 years of len maintenance versus len until CR and then stop. And the patients who got len until CR had a shorter period of drug exposure and had an inferior progression-free survival when compared to 2 years. There were different induction regimens up front, which made it a little bit complicated. But even when you compare the 2-year to the other trials, it doesn't seem to have as long a progression-free survival. Now, at the risk of cross-trial comparisons, which you're supposed to not really do, there does appear to be, though, that both myeloma 11, CLGB 100-104, and the Jemima trial, RV209, all had long progression-free survivals. The French study, 0502, stopped it due to a second cancer signal. And so they had a shorter period of time, an average of 2 years. So we sort of struggle with this, but for now, the standard remains maintenance until progression.